So next is the principles of general anesthesia. So what are the three main components of general anesthesia? Number one, unconsciousness or hypnosis. Number two, analgesia. Number three, muscle relaxation. Each patient requires a balance of these three components, and depending on what kind of surgical procedure the patient has, either patient needs muscle relaxation or not muscle relaxation, and the duration or length of the procedure. What hypnotic agents are available? So it's IV and inhalational. In IV, it's a propofol, thiopentone, ketamine, and etomidate. And ventilatory agents are sevoflurane, isoflurane, desflurane, and halothane. And what opioids are used in anesthesia? So in anesthesia, range of opioids are available. It depends on they have different potency, onset time, and duration of action. And mostly they depend on the hepatic or renal excretion. So they cause dose-dependent respiratory depression as well as cardiovascular depression. So first of all is remifentanil. It's synthetic, ultra-short acting. It is metabolized by plasma esterase, and it's usually given to suppress the sympathetic stimulation. Then is the fentanyl, 100 times more potent than the morphine, typically used in the induction of the anesthesia, can be used in PCA for post-op pain. Morphine, most commonly used drug for post-op pain, either PCA or IV or oral doses. What drugs provide muscle relaxation under anesthesia? So they are divided into depolarizing and non-depolarizing agents. So polarizing agents are succinylcholine, which is a short onset 45 seconds and short offset 4 to 5 minutes. And they block non-competitively, and they're broken down by plasma cholinesterases. About 5% of the population have abnormal plasma cholinesterases, which have a prolonged block, maybe 4 hours. And non-depolarizing muscular blockage are the atrocorium, rocorium, and vicorium. And longer onset and offset dependent on the dose. They're competitive blockage, so they can be reversible by neostigmine. The succinylcholine was non-competitive blockage, that's why it cannot be reversed. What are the common complications, side effects associated with the general anesthesia? So again, hypotension, dysarrhythmia, loss of protective airway infection and respiratory drive, hypothermia. Post-op patient may have peripheral nerve injury, sore throat. So again, it's a lot. It should be classified into system-wise, dose, drugs-wise. What is the post-op nausea and vomiting? It is nausea and vomiting occurring within 24 hours of the surgery. The etiology is unclear. It could be due to surgical anesthetic drugs and the patient factors. Most patients are female gender, non-smoker, previous history of post-op nausea, vomiting, and history of motion sickness. Anesthetic factors are volatile agents, large amount of neostigmine and naltrexone and opioids. Surgical factors, duration of surgery, and type, gynae, and urology. What mechanism control the vomiting reflex? So vomiting center is located in the medulla. Vomiting reflex may be triggered by any of the 5 afferent pathways. Number 1, chemoreceptor trigger zone. Number 2, vagal mucosal pathway in the GIT tract. Number 3, neuronal pathway from the vestibular system. Number 4, reflexes from the cerebral cortex. And number 5, afferent from the midbrain. So what drugs are used in the management of post-op nausea vomiting? Antiemetics may be used prophylactically and as treatment for post-op nausea vomiting. Several classes of drugs are available and act as different parts of the pathway controlling the vomiting reflex. So 5-hydroxytryptamine receptor antagonist. And number 2, antihistamine, dopamine antagonist, and the steroids. Multiple agents may be necessary to prevent post-op nausea vomiting. Thank you.